The information provided on this podcast is for general informational purposes only and is not intended as a substitute for professional medical advice, diagnosis, or treatment. Always seek the advice of your qualified health provider with any questions you may have. Never disregard professional medical advice or delay in seeking it because of something you have heard on this podcast. Reliance on any information provided here is solely at your own risk.
Welcome. This is Birth, Baby. Your hosts are Ciarra Morgan and Samantha Kelly. Ciarra is a birth doula, hypnobirthing educator, and pediatric sleep consultant.
Samantha is a birth doula, childbirth educator, and lactation counselor. Join us as we guide you through your options for your pregnancy, birth, and postpartum journey. Thank you to our listeners for your continued support. If you enjoy our content, please be sure to like, follow, rate, and review wherever you listen to podcasts. This helps us gain visibility to other people that could benefit from listening in. Hello, everyone. We are back with Leonora Colen, and she is here with HomeBirth Honey, or from HomeBirth Honey, with Birth Baby Podcast, because we love having her here. And she's here to chat with us about what in the world is a high-risk pregnancy. Thanks for being here with us.
So happy to be here.
Another hot button topic we've got here today. I think half the people that we talk to in the initial interview process tells us at some point or another that they have a high risk pregnancy because maybe they were told by someone that they have a high risk pregnancy, or they, just assumed so because, maybe they're 35 and they're considered advanced maternal age, or, different things like we've talked about that in the past. But with all of that, so many people feel as though they're high risk. We know that all of those people are not high risk. So as a medical provider, how do you define a high risk pregnancy?
Yeah, so I don't love the term high risk. When I'm looking at somebody's overall health picture, I prefer to talk about their risk assessment. So anytime I come into contact with a client, if they're reaching out to me as a potential client, or if they've signed up and they've submitted their health history, or just even at like a regular prenatal visit, there's always some form of risk assessment going on. Because when you're looking at birthing out of hospital, you definitely want to make sure that your pregnancy is considered low risk so that it's safe to be at home. So I would be more likely to be looking at somebody's risk assessment and then looking at different factors in their health history. Different factors like family history, thyroid disorder, lifestyle. Do they have a sedentary job? Age is on there, but it's just a factor. It's not a risk factor that I'm significantly worried about. I think that there are kind of three different categories that I want to talk about today. I want to talk about a few of the ways that you can risk out of care, out of midwifery care into OB care, or in OB care into like a higher level of higher risk OB care. There are more factors than I can count. There are all sorts of rare pregnancy-related disorders, and I don't think it's helpful or a good use of time to talk about every single one. But I did want to talk about, I'll say, the top three. One of them, the most common reason I would say that we as home birth midwives tend to risk people out of midwifery care is preeclampsia. This is going to be a full diagnostic picture. It's not one thing, it's lots of different things. The abbreviated way to explain it is basically that your body has an allergy to this pregnancy, to being pregnant, and that the only way to halt the physiological process that has started with this is to deliver the baby. So things that we see with pre-E are going to be blood pressure, swelling, protein in the urine, sometimes visual disturbances, blurry vision, or seeing auras, pain up under your ribs that won't go away, that doesn't really seem positional. Those are going to be things that we look for. And then we're able to do diagnostic tests like a 24-hour urine collection, which is exactly as onerous as it sounds, or blood draws where we can check your liver enzymes, among other things. These are all ways that we can check in and get an overall picture of what's going on. If somebody is starting to develop pre-E and they're like 41 weeks, we're going to do everything we can to get them delivered as quickly as possible if it's still safe for them to deliver out of hospital. If they're 37 weeks and labor is not looking imminent, and especially if the protein in their urine is really high or their blood pressure is really high, it's probably going to be safer to transfer into OB care so that they're able to set you up for an induction if needed, if you don't go into labor spontaneously. That's going to be the most common reason that we wind up having to risk people out, especially towards the end of their pregnancy. Also hypertension, which, shares characteristics with pre-E, with your blood pressure being high, but hypertension and, what we would call it is pregnancy-induced hypertension, usually because it's not pre-existing hypertension. Otherwise, you wouldn't have been a good candidate for midwifery care. But pregnancy-induced hypertension usually looks like at some point in the pregnancy, your blood pressure starts to creep up. And there's definitely things that you can do to help with blood pressure, like, regular exercise, eating a normal to low amount of salt in your diet, trying to reduce stress, doing things like meditation. But if it's pregnancy-induced hypertension, it's not your fault. It's just the way that your body is reacting to that pregnancy. And when blood pressure gets high during pregnancy, it's not safe for mom or baby. So in those cases, sometimes a medication is required to bring that blood pressure back down. And in that case, they do need to be supervised by an OB for the duration of their pregnancy. And then the last one, which is more rare, but also kind of interesting, is cholestasis. Cholestasis, like I said, it's really rare, but the way that we often find out about it is that somebody will start to complain that their palms and the soles of their feet are itchy, which sounds like such a strange symptom. But basically, cholestasis is a slowing of bile through your liver. And you can do a bile acid test to check and see where the bile acids are. And if you develop cholestasis, again, typically you're going to need an induction to get that baby out safely. So those are three of the more common, just like, yeah, this sucks, but you really do need to probably get induced in that situation. I could go into other ones, but those are really the main ones, other than potentially like butting heads with 42 weeks of pregnancy and not being in labor yet and not getting into labor. That would be another indication possibly of needing a hospital induction.
I love that you're saying those three like right off the bat, because when I teach hypnobirthing classes, I go over it's actually not even really part of hypnobirthing, but I just add this in because I think it's really important, is what are the reasons for induction? Like, why may a provider want to induce you? And I have a list of them, and during them I'll be like, and this one's full stop. Like, this one is not really a negotiable. Like, you can choose still, but like some of them are really medically necessary and others are, I'd feel more comfortable if you did. And it's preeclampsia, it's hypertension, it's cholestasis. And so all of those things, it's funny because there are some things that just come on during pregnancy and you just have really no control over it. Like gestational diabetes, if all of a sudden it's not diet controlled and you have to use medication, would that be another one that would risk you out, right?
Yeah, I was actually going to talk about sort of a mid-level of risk factors. It's funny because people think of gestational diabetes as a reason to be transferred out of midwifery care. But 99% of our clients that develop gestational diabetes, which is actually quite common, do not require medication, are able to keep their blood sugars in a nice steady range just with diet and exercise. So that certainly is a risk factor. But the really cool thing about GDM is that if you test for it and you test positive for GDM and you are followed by a maternal fetal medicine doctor and you check your blood sugars and they're staying within a certain range, it basically takes the vast majority of the risks associated with GDM and reduces them to almost nothing. It's still a factor. It's still something we take into consideration if somebody's delivering with us and they do have GDM. But we're not as worried about a bigger baby, about shoulder dystocia, about blood loss, all those things associated with GDM that are more likely to be seen in a either not diagnosed case or poorly managed case of GDM. And yeah, you're right. You know, some of these times that these things are noticed during pregnancy, we have people who are like, what about, you know, what if I start doing the acupuncture that you recommended? And what if I, you know, do this and do that? And it's like, when you're talking about, you know, severe hypertension or preeclampsia, I mean, when you follow those risks all the way to their conclusion, you are talking about fetal demise. And so we, you know, definitely in all cases are always trying to reduce the risk of that happening. Not to be fear-mongering, not to, you know, make people feel like they have less choices, but more just to make sure that all of the information is presented to you in this case so that you know why we would recommend that you get induced at that time.
I think that's why it's kind of hard for us, is because a lot of the people that hire us tend to be a little bit questioning of the medical system. They're really just not very trusting. And so we're not medical, but they look to us to go, is this for real, for real? Like, do I really need to be worried about this? And so there are some things where it's very easy for us to say, like, statistically, here's the evidence. We just show them the evidence. This is the risk factors, right? Like, or this is the risks of this happening. And that's where like that fine line is between, we don't want to scare you, and we also are not medical, so we can't be giving you medical advice, but this is really probably a pretty legit reason to be going in. But they're mistrustful from the start, and that's what's really difficult.
And I totally understand being that way. Like, I feel like there are so many times, especially as women, where we are gaslit with our own healthcare, where we come with questions, with concerns, where we are told to lose weight, do hormonal birth control, not listen to. And it is deeply frustrating. It is rage-inducing to me. It's why I, you know, get my advice now from an amazing healthcare provider that is not part of the, you know, the sort of Western medicine system. But it makes it really complicated when real risks come up and real interventions are needed to know, you know, what's real.
And I think exactly like you just said, a big part of this for people who are, you know, a little bit more questioning is working with a provider that you trust, so that when they are telling you those things, that like, hey, you are, you know, your bile levels are at this level. This is considered cholestasis. This is kind of the risk level that we're at. Let's talk about induction. You're not immediately like, okay, but like, who else can I talk to? Let me go get a second, third, fourth opinion from, you know, all these different people, bloggers on the internet sometimes. But this is why, as doulas, we feel so strongly that you need to work with providers that you trust, so that when they give you that information, you know that you can trust that information.
Absolutely. Trust is huge in that relationship, especially when you're pregnant and, you know, more vulnerable. Not everybody, you know, for financial reasons has access to midwifery care. I'm always so happy when people who are planning to deliver in the hospital wind up hiring a great doula team as well, so that at least they have access to somebody who can help them, you know, find good sources of information. I do want to talk about factors that people will come to me thinking are significant risk factors and are reasons that would keep them away from midwifery care that for me are not. A lot of times, like you said, people will be like, I'm 36. Can I deliver with you? And I'm like, girl, we have no restrictions on age. We have had like first time moms deliver at home at 45 with us. Like it is all a spectrum, and, age is just a number. We do talk to people who are, past their late 30s, about the way that our hormones change in our body. And what that can look like is sometimes the body is less likely to go into labor spontaneously. So different things that we can do to help with that. But is age a health factor? Yes, absolutely. Is it a reason to not consider midwifery care? Definitely not. Other factors are going to be thyroid disorder, super common as long as you've got co-management with a physician and a prescription if needed. That's totally fine. Mental health. It's definitely something that we want to, again, take into the whole picture and make sure that if you are having significant difficulties that you're getting the help that you needed. But if you need a low level of Zoloft to help you tolerate the craziness that is being pregnant, and you've got a great physician who's, writing that prescription for you, we are happy to take care of you. And we would rather that you are getting the help that you need rather than you're white knuckling your way through the pregnancy, experiencing extreme distress. Also, previous C-section. We love VBACs. We love to help moms who have had who have had a C-section with a previous delivery, experience that amazing home vaginal birth afterwards. HomeBirth Honey, I don't know why, we get just a ton of VBACs and we love to help them. It's definitely a specialty for us. And again, is it a factor? Yes, we definitely know for our moms who have already had a C-section that we're going to be watching them just a little bit more closely and maybe not offering things like castor oil. But great success with the vaginal home birth after C-section, and not a factor that should keep you away from considering midwifery care unless you had a vertical incision with that delivery. And then quickly, I wanted to talk about factors that people might not actually consider risk factors that we consider risk factors when we're talking to them. So that would look like lifestyle, having a sedentary job where you are 8 to 9 hours a day seated in front of a desk and you're so wiped out from that job that you just don't feel like exercising when you get home. A really sedentary lifestyle is not a great fit for planning a home birth. Birth is a really athletic event, and we are not expecting you to go to CrossFit or be taking Pilates every single day, but we are expecting you to stay active in some way. And, if you have a desk job, what that might look like is getting a yoga ball to sit on the ball, maybe even getting like a standing desk or a walking desk that you can use intermittently, but also factoring in exercise on the weekends and at least a few days a week, just so that you can help move that body, help move those hormones. It really, really changes outcomes. And then
that was going to be surprising for some people to hear. Like, what? They might take that. I can see someone hearing that and going, well, so you're judging me because I have a job, like you're saying, but it's not that. It's literally that if you have a sedentary lifestyle, we're not judging you. That is just what it is. But it makes it higher risk for you to have a home birth because you may not be able to do some of the things needed in order to, and also your body may just not react in the way that it needs to react because of that. So I love that you're mentioning that.
Zero judgment, just, consider changing it up if it's possible. I remember in my first trimester, I was working full-time at the birth center, which full-time there is full-time. And the fatigue that you feel in the first trimester, that feeling of like, I could almost fall asleep at any moment. And I had, 2 stepchildren at home and, was so busy. And the last thing I wanted to do was go to the gym. Like going to the gym, really, I would think about it and my heart would crumple. And then I would get there And I would do, 45 minutes of cardio and lift some weights and listen to a podcast. And I would come out feeling great. And I'll be like, oh, yeah, I have to do this. I got to do this. And then, so I just kept it going and kept it going. And then in the second trimester, it got easier and you find things that you like to do. But it's kind of like a negative feedback loop. If you're not exercising, you don't feel like exercising. So you just got to do it. And then diet. Eating a super processed, unhealthy diet with lots of sugar. Our culture glorifies that type of eating, especially during pregnancy. It's like, oh my God, eat for two, have fun. And it's like, it's really the one point in your life that you should be really thinking about what types of foods that you're eating, not counting calories, not restricting yourself, but focusing on protein, on unprocessed foods, so that you feel well and continue to feel well through the pregnancy. We know you feel hungover through the first trimester. We're not judging you for living on saltines and noodles and what have you during that time. But once you start feeling better, you got to add in the smoothies, you got to add in the protein, you got to figure it out and clean it up, because you are not going to feel great during the rest of your pregnancy if you keep eating that way.
Yeah.
And then the third risk factor I wanted to talk about that I think that people don't think about, but that I consider a huge risk factor, is first-time parents who do not avail themselves of childbirth education. You can be watching YouTube videos every single day. You can be reading blogs. You can be all over Instagram following all the influencers who have home births and free births and, are drinking raw milk and all this stuff. But you do not know what to expect when it comes to birthing your first baby at home, breastfeeding that baby, taking care of that newborn. There are rare people that come through our care who are like, yeah, I'm one of like 8 siblings and I have 20 cousins and I've been taking care of babies since I was 6. And I'm like, okay, I get it. Like, you know how to care for a newborn, but you still need breastfeeding classes and you still need childbirth education. There's so many different types of childbirth education in Austin. We're so lucky. I know you guys have great classes. Our student does an amazing class. There's tons of classes around town, and there's hardly anything more important you could be doing while you're pregnant than getting those classes.
We as doulas even require it, because even though we are educators, we don't even require that people take our classes. You just have to take a class, a comprehensive childbirth class, because we can't possibly teach you everything you need to know in our prenatals. There's hours and hours of those classes typically. And you just don't know what you don't know. And there are going to be situations that come up that in most births, there's something off the wall that happens that you maybe didn't even think about or plan for. And if it's the first time you're hearing it, it's like drinking from a fire hydrant and then you don't know what to do.
Yes. And they are, if anything, more for the partner than the birthing person. The people that I find whose minds are the most blown by having all of that information downloaded are the partners. And I can always tell at a birth if it's a first-time couple, which partners attended classes and actually stayed awake and paid attention during classes, because the ones who didn't are freaked out, and their partners see them freaking out and then they freak out. And it's just this like really negative feedback loop between the two of them where they're like, this isn't normal. This isn't normal. This isn't normal. Even if we're right there next to them being like, this is normal. This is okay. It's like you said, there's only so much we can do in the moment. And a lot of that information needs to be downloaded prior to delivery.
I had a class last night, perfect example. Class 2 of my hypnobirthing series. Couple was in person for the first time. They were online last time. And I showed a video at the end of class, and it was a water birth. And someone asked about the baby's head being underwater. Why did they keep telling the mom to keep her bottom in the water? Because she was starting to come up. And I was like, it's completely safe. And I started talking about like, you don't want to come up and go back in because then the baby's face has touched the air and then it's not safe to go back underwater, blah, blah, blah. And actually, these people are your clients. They're not our clients, but I know they're your clients. And the dad was like, and he's actually a huge proponent of home birth. He loves it, but he didn't know that. And he goes, oh my God, I'm so glad you told me that. Because I think I would freak out if my baby was born with its head underwater like that. And I was like, Yeah, buckle up, friend, because we're going to have a lot more videos in this class, and I'm going to make sure your eyes are open because you don't want to freak out in the moment at the birth. You want to enjoy your birth, not be traumatized by something that actually isn't traumatic, but only because you didn't know it was okay. It does feel traumatic if you didn't know. So very important.
I've had partners tell me after the fact, like, oh my God, the baby's face was purple and you were acting so calm and, happy. And I thought you were just trying to smooth it over. And I was like, no, bro, your baby was fine. But they were just like sweating and crying. And like, oh, that moment could have been so much easier for you.
Yeah, we talk about that all the time. Like the things that people perceive as high risk or something that went wrong when really it was normal, but no one explained that to them. That's so hard. That's so hard to hear about, especially the second time when they've like lived with that for a while.
Yeah. I think when we're talking about high risk or risk assessment and risk factors, it's really important to circle back and talk about how the body is going to do what the body is going to do. And all you can do as a pregnant person is to make the best choices that you can make. Move your body, eat well, get high quality childbirth education and newborn and baby education, choose providers that feel, respectful and kind and that you trust. And then kind of release your experience into the world, because it's kind of microdosing what it is to be a parent. How, you do your best and you try your best with your kids, but sometimes they get sick and sometimes they have disabilities and sometimes these things happen and they very rarely go back to being somebody's fault. So just make sure that when you are thinking about these things that you're not thinking, oh, this is because of me and I did this and I should have done that differently. Like I said, just make the best choices you can and know that like this world has something in store for you and you don't know what it is yet.
Yeah. I think one thing that I have taken as we have been talking about all of these different factors is that there's all of these things that could potentially make someone high risk. Maybe they need collaborative care. Maybe they need, a different intervention. But there are interventions, whether that's a diet change or an exercise change or, getting more sleep, or maybe it's biophysical profiles a little bit more often, different things like that, talking to an MFM that can address these things in an individual, process. So, yes, all of these things exist and there are things that are going to make other things more likely, but we can do things to catch those before they become a problem, or we can do things to hopefully prevent them from becoming a problem as well.
Absolutely.
Awesome. Well, thank you for coming on and talking about this. I think this is such a great little nugget for our listeners, and I'm excited to be able to share this. And thank you so much.
My pleasure. I love talking with you guys. Could talk all day.
Absolutely.
Us too.
Okay, bye.
Thank you for joining us on Birth, Baby. Thanks again to Longing for Orpheus for our music. You can look him up on Spotify. Remember to leave a review, share, and follow wherever you get your podcasts. See you next week.